Yes.
that if you have had some exposure and you don't know the partner well or you made a mistake, come in for a checkup.
It's more effective in the first 24, 48 hours. If there's more time, it's less effective.
Last week I had a pregnant woman that they sent her because she have IgG for rubiola positive, and I have to explain to her that this is nothing serious.
Dangerous. Why are the numbers and incidents are on the rise? Is it something that we came out of COVID and people are just less careful? Is there not enough awareness in Dominican Republic about HIV?
I can say like I had like 5 or 8 years, I never seen a syphilis, primary syphilis. And last 2 years, I've seen a lot of primary
Wow.
syphilis.
Welcome to another episode of Real Talk with Dr. David Samadi. You know, this episode is a little different than some of the ones that we've had. Infectious disease in Dominican Republic in some parts are growing, whether it's sexually transmitted disease or HIV or AIDS or syphilis. And I couldn't think of any better team in Dominican Republic than the Infecto team. Dr. De Luna, welcome to the podcast, and
Thank
Dr.
you.
Roque, some of the best infectious disease experts in Dominican Republic. And as you know, they are from homes in Santiago, but they also see patients here in Santo Domingo at MedWork Global in Piantini. So we're very lucky to have you in our podcast, and I want to learn from you guys.
Thank you for the invitation.
Thank you very much. Finally, we're here.
That's wonderful. Before anything, I want to get this out because husband and wife both are infectious disease. I've never seen that before. Tell me, how did this come about and what's the background? How did you guys meet? And how is it that both of you are in the same field and live together?
I think it was by chance because I first get to the hospital. We all met like very years ago just as students, but we didn't have too much relation between us. And later, a few years...
You were the attending first.
Yes, I was the attending first.
But we were both in relations before. So he was in a relation, I was in a relation. And then that's why he said we met, but we didn't get together. Many years after, then we met again in the hospital. He was already in infectious disease. I was in internal medicine.
You were a doctor at that time, or you were training?
Yes. We were both training. He
I
was
wasn't
already
training in infectious
diseases, and I was in beginning internal medicine.
I see.
So that's where we like re-met. Then after that, a couple of years, and then
Wonderful.
the magic happened.
That's
Yes.
great. And you have been in practice for how many years now?
I have like 15 years working. I started in
Long
Santiago.
time.
Yes, a long time.
I have 12
That's,
years.
that's wonderful. And you're based out of homes, and I know you've taken care of few of my patients, and they're extremely grateful and happy with the work that you're doing. Look up Infecto team, and we're going to find out what kind of patients that they're going to see. How is the experience in Santo Domingo? Are the patients similar to people in Santiago or different, more demanding, less demanding? Are we seeing the same kind of like infectious disease?
Yes, there are like kind of the same infections. This is mostly infectious ITUs, STDs, from the skin infections. Let's not say they are more difficult. They are a little different, but I think it's not because of the infections. It's like the city. You know, Santiago is El Cibao. It's a little more like different from Santo Domingo, but they are the same. That's easy to go.
Yeah, I think in Santiago we have more a board of cases, more kind of cases to see there. People select us for different topics to see and to talk about us. And I think here in Santo Domingo is something more specific, kind of diagnosis that they go to there.
So in my field of urology, we obviously deal with urinary tract infections. Most of the time with antibiotics and cultures, we're able to take care of them. But for some of those cases that are very challenging and difficult, or they may need extra step that even urologists are not good to handle, you guys have been very great when it comes to those kind of patients. So I know urinary tract infection is one of the types that you see. Tell me about some of the other patients that you see in your practice. You said sexually transmitted disease.
Yes, sexually transmitted disease, including syphilis, including HIV, AIDS, of course, and all others like chlamydia, gonorrhea.
Somebody has had unprotected sex. And I'll give you two scenarios. 3 days later, they see some discharge. They freak out, they're panicking, and they will come to you. And another person has unprotected sex, but they have no symptoms. What should they be doing? Obviously, the one with the discharge is going to run to your office, panicking like, God, something is up. How about talk about both? The one that has no symptoms, what should they be doing?
In both cases, we have to evaluate, because even though the one that is symptomatic, the one that has the discharge, we have to look for some other STDs. Even though maybe that one is gonorrhea already, for the discharge, we're going to suspect gonorrhea, but we have to look for other ones, because mostly all of them, they are asymptomatic in the first phase of the disease. So for both of them, they have to be evaluated.
They get what? They get a penile swab? They get a swab?
Yes. You have to be like a syndromic view. You have to look out a lot of diagnosis, or two or three, four diagnoses. And what we do is to make like a sample. We can do one of the choices to make a swab, take a sample, and send it to the lab, looking out like 4, 5, or 6 bacteria that can be also parasites.
As well as blood.
As
well as blood, but blood do not help too much in the first days, because for blood we can take out maybe HIV in the first days. We have some tests like the P25.
But it may take some time.
It will take some time. But if you want a quick diagnosis, especially in the patient that have a discharge, the better thing to do is to make a swab, and with that swab, we can find out like 4 or 5 bacteria that can be. One of them is like chlamydia, gonorrhea, and other ones like uroplasma and other.
And of course, different antibiotics for each one of these diseases, or you have a broad spectrum antibiotics that you give them?
Mostly we use like directed antibiotics for what we find, because there are, for example, gonorrhea, you need some antibiotic. But if you have chlamydia, it's another antibiotic. And usually gonorrhea and chlamydia, they go together. If we find one, maybe the patient, we have to treat both. And we have to say that even in the first days, the blood test is not going to help a lot to diagnose a newly acquired infection. But we have to make sure that this patient, that when they come to us, we have to make sure that he doesn't already has any STDs. To then follow up see.
After you take the specimen, do you give them a couple of antibiotics on the way out?
Yes.
Do they get like doxycycline or something else to cover everything?
Yes. You have to give the treatment at least for gonorrhea and chlamydia when the patient have a discharge.
Which is what?
You have to do like...
What's the best medication for that?
No, the best thing is to do is doxycycline and ceftriaxone.
That covers everything.
Yeah, that covers everything in the first time. Especially if you cannot make the diagnosis in the first hours or in the first day.
But what you say is okay, because we have to take the test, and until we wait, we cannot sit and wait for the result. We have to treat. And if we lose that time, that precious time, the patient could progress. So we take the test.
So that's a good lesson to so you can tell that to the public.
Yes.
That if you have had some exposure and you don't know the partner well, or you made a mistake, come in for a checkup, because the earlier they find this, they can treat you, and then you don't have to suffer from, right?
It's more effective in the first 24, 48 hours. If there's more time, it's less effective.
The other important is that the follow-up. Both patients that you present, you have to follow up at least for 3 months. We have to do at the 1 month, the first month, you have to do HIV, hepatitis B, and hepatitis C. And after that, you have to do at the month 3, repeat the 3 tests to be sure that this patient did not took the infection
I see.
in the relation.
So somebody has had a sexual activity with an unknown person. How long they have to wait until you clear them that you don't have HIV? Is it 2 months? Is it 3 months?
At least 3 months.
3
but
months.
it will depend also, because if you find that the patient have like hepatitis C positive in the month 3, you have to continue the follow-up for the other infection at the 6 months and even at the 12 months.
That's a disaster. Hepatitis is even
It's worse.
sometimes
It's
worse
It's
than
worse.
HIV, right?
Mm-hmm. Worst.
Something important with hepatitis C that in these few years, it's you can cure. You can give treatment and the patient can rule out the
Clear out or
clear out infection.
the hep C.
In the past, that was a chronic disease. Yes.
Why are the numbers and incidents are on the rise? Is it something that we came out of COVID and people are just less careful? Is there not enough awareness in Dominican Republic about HIV?
People is being less careful. After COVID, after the pandemic, as everyone was like, is not going out. Everybody was like in reclusion. After pandemic, all STD are rising up. Primarily syphilis. I had like, I can say like I had like 5 or 8 years, I never seen a syphilis, primary syphilis. And last 2 years, I've seen a lot of primary syphilis.
I think also it's not too much education in the schools, and even the public health is not giving too much information to the teenagers to avoid that they have like a relation without protection, or avoid that they have too soon from their age.
Public education
Yes,
is
we need
where
that.
they need to concentrate on.
Well, above that, we as parents, we need to educate our kids. Everything
Yes.
starts at home. And those are topics that us as parents, we are like scared to talk with our kids. We think like he's not old enough to talk about that. But for my experience, our experience, we talk to our kids about it because infectious disease kids, they have to know about.
The sooner they know, the better
yes,
it is.
so
Yes,
the
that's right.
sooner that they know.
So in men, you deal with STDs, you deal with urinary tract infections, and of course, like skin disease in men. All the range of pneumonias and flus and those kind of things.
Bones, infections, osteomyelitis. Here in this country, the accidents are
Trauma.
very, very, very
Very frequent here.
frequent.
Here is one of the countries with more accidents in the whole
The
world.
motorcycle,
The
right?
motorcycles, and we have a lot of patients that when they have the fracture, that the bones get out,
Oh,
it can
God.
get infected, and it's very frequent for us to see patients with osteomyelitis. That it can be a very chronic disease for these
And
people.
those are treated in the hospital, obviously. You
Initially.
usually admit them.
Initially, it depends. Sometimes we make some strategics to get the patient inside the hospital for a few days, like 7 days, and later send the patient with antibiotics and the follow-up in our office.
Do you also work with these not inpatient? What do they call them? The when the patient goes home with the PICC line, and you have a team that actually go with the patients. They put the PICC line, and then they kind of like.
Yes.
What are the nursing services that they have? Do we have that in Dominican Republic?
Yeah, well, we have something like that here. It's not like in the States,
It's
what
not
we
like
do
an
here-
OPAD. In the
yes.
States, it's like an outpatient antimicrobial
Yeah.
therapy.
Well, they put a PICC line in the
Uh-huh.
hospital,
Yes.
and then the nurses show up at their house and they give
Yes.
the antibiotics.
Yes.
The-
But
the-
here, it's not like that. Okay.
Okay. The big problem here is that the insurers do not pay the antibiotics for the
And
patient
they're-
outside. The patient have to pay. They are drugs.
Insurance companies
some
are a
insurances-
disaster everywhere.
Some insurances does,
Yeah, sometimes,
Some-
but we have to do a hard work with that insurance to they accept it, not for all patients, but we do it here.
Well, you guys should start something, a infectious disease service at home. If
Yes,
if this
it
doesn't
looks like a good
exist,
idea, yes.
that would be a very nice concierge
Mhm.
that we come to your home, we will give service. It's just an idea, especially if it doesn't exist. A lot of these people, they don't want to and you know what? You will stop the overflow of all these people that are going to come to the emergency room. They come to get some IV emergency room and they end up having a pneumonia.
You're very right. The thing is, the antibiotics we use usually are the expensive ones. The broad spectrum antibiotics are not the ones that you go to the pharmacy and you get them
These are like
the expensive.
Zosyn.
Exactly. And what happens? When you talk to the patients, there are some patients that prefer, okay, I go to my house, I get a big line, every other day I go to make the medications, but the cost is very high. So sometimes if you get the patient to the hospital, okay, the insurance is going to cover. But if you send them home, they don't cover.
Something to think about.
Yes. We have to talk about it.
Something to think about, because I think there's always opportunity for people who just want the convenience of take care of me, and they're willing to pay for it. I think that's okay. Let's switch to women's side now. So you see a lot of, I assume, vaginal infections.
That's my specialty, So
this is another interesting, but it's not separated where you see the guys and you see the women, or it is?
No, the women are more confident with her to talk about,
So that's another benefit of the Infecto team. We have covered both men and women.
Yes. But you're right. I see a lot of women, young women, old women, postmenopausal women with vaginal infections. Usually what we call recurrent vulvovaginal or vulvovaginitis. They usually come to my office when they have many months or years treating.
This is from having frequent sexual partners, or from what?
No, that's like a risk factor, but not for this one, because the most that I see is from Candida, which is a fungus.
In older women,
and usually
diabetic.
No. All the ones that I see, all the recurrent vaginal infections I see, the most frequent microorganisms that I see is Candida.
Wow.
The thing is that there are so many medications not for Candida that people use. Like OTC, they go to the exactly, and they go to recurrent infections. They don't resolve. They don't see what's happening or outside the vaginal infections, and they don't see all the things that could affect that, and that's really a problem.
And the point is that a lot of time, this patient go to a lot of doctors. Every doctor give a treatment, and usually this treatment is antibiotics. And if they have a Candida, the Candida get worse every time.
Mm-hmm.
And sometimes they go to the office, and what you say to them is to take off everything and to wait some time, and you see her again a few weeks later.
And they're better.
And they will get better, or you can get a better approach to the patient with the treatment just for the Candida.
I think what's unique about your team is that it's so focused on infectious disease, because I think a lot of primary care doctors or internal medicine people are treating infections, but they're not as focused as you are. And this teamwork makes a big difference, because you go extra layer of search. And I think for people who are diagnosed with any kind of infection, and I know there are a lot of them are frustrated, because even in my practice, I see even young girls, 22, 24-year-old, constantly keep coming with these urinary tract infections. And of course, some of it is hygiene, some of it is after sexual intercourses, some of it is, the vicinity of urethra to vagina.
The vagina, yes. That said, usually we, as infectious diseases, we don't see like the primary manifestation. We see a syndrome. So we try to look for what's happening outside of what we are seeing to try to get better all those things so this can get better. Usually what you say is right. I go to the doctor give me a medication for my urinary tract infection, and that's okay. But then next time, they didn't see that I had something in my renal, in my kidney. They didn't see that I have something outside that is making me have that urinary tract infection. So it comes again. So that's why we are like more focused everything we have to see like a syndrome.
So these are obviously like very general, broad infections, but there's also a lot of other ambiguous stuff. For example, like I know a internal medicine doctor constantly looks for mold, looks for Lyme disease, looks for all these, like I get these reports of like 50 pages of, besides all the IgA and IgE and IgB and IgG and all this stuff, here he is looking for mold, he's looking for this. Is this true? Should we be doing this kind of like screening or?
Yeah, to our office, we have too much time patient with fevers that they don't know where it comes from. And one of our approach is to see this patient and to help them to know what is the reason of this fever. And that's the times that we do that, things like you said, that we have a lot of tests doing to rule out what is causing this kind of fever. And as you say, a lot of time the patient get IgG, IgM, and all the Igs positive, that they can have. And this can make some confusing just for the doctor and the patient, because having an IgG positive do not mean the infection is there. A lot of time it means that the infection is not there and it's in a past infection. But the patient get to the, last week I had a pregnant woman that they sent her because she have IgG for rubeola positive, and she was very scared because
pregnancy.
The pregnancy. The doctor told her that he have rubeola and they have some consequence for the baby, and I have to explain to her that this is nothing serious,
dangerous,
nothing dangerous. Maybe she was vaccinated, or maybe she had the infection when she was a little younger. But our biggest approaches is to see how a patient why he have fever. That's why sometimes we send the patient to make blood cultures to see if they have any kind of bacteria inside the blood.
I'll give you a live example. Maybe I take advantage of this.
Okay.
My son calls me about like a month ago, and he says, "Dad, I'm starting to have some skin changes. Like a eczema or some like not psoriasis, but some like lesions, and it started from here and it's expanding, and they checked everything was completely negative, and now he's telling me that they're looking for mold. Is it because like he went to a new dormitory and the doctor thinks that maybe like they should be checking for mold? Could that cause this kind of like skin disease, or they're not in the right direction?
No, I think it can be, but they have to make some tests to the skin, like there are tests called it
biopsy.
Biopsy, but the most
KOH.
simple one is the KOH, where you can see in a smear, right? You can see if there is some mold in the skin.
I see.
Okay.
I
That's
see.
an example. If they don't find it, other thing they can do is a biopsy to see what else.
Well, if they cannot find it, I'll tell them to get in touch with Infecto team.
Yes.
Infecto team in Santiago and Infecto team in Santo Domingo. How about that? They
Very
solve
good.
all the problems.
Very
Without
good.
them, the whole country will be so infected you don't want to even be here. They'll take care of everything.
Oh, wow.
What else do you guys? I know like you deal with a lot of bad pneumonias. I've seen like you guys
But-
in action.
Well, something I want to say about what you talk about. You see, us, infectious diseases, we usually take much time talking to the patients. We have to do like a very long history, clinic history, because when that happens, that this patient comes, has a fever, he doesn't know, or she doesn't know where it comes from. We have to see all the travel, animals, all the food, everything, even years ago.
That's right, traveling abroad.
Yeah,
Yes.
even years ago, and that helped us to decide which of those IgG,
I see.
IgM we need. It's not like, okay, I have all these IgG, let's ask for everything. No, we talk, maybe in 5 minutes, 20 minutes, we have everything, but sometimes we have to wait until something comes up from that
I know.
history.
I know you've taken care of my patients, so I can personally say that a very thorough team, details, and I think a few years ago you take care of another patient of mine. It was a post-surgery, and we were really... listen, doesn't matter what you do, you're going to get a couple of patients a year that normal antibiotic is not going to take care of them. And I came to you and you took care of them, and you've done some for our patients. So that's the reason why we're here talking about this, because I want people to know that this service exists, that we have great doctors. They don't need to run to all these hospitals in Miami and New York. We have great, smart, infectious disease experts here.
And they can come directly to us. They don't have to wait that other doctor or other person to tell, go to infectious diseases.
I have another great question. Let's say somebody is off the street. They're perfectly fine. They have no symptoms. Are there anything that you guys like usually screen for general public? Should they be looking for things or not? Or we don't normally do that?
Prevention, and that's with vaccination. Right now, we are in the era of vaccinations, and we have so many vaccines here that not only kids, but always adults, everybody has to be vaccinated. So for an adult,
what do you recommend?
We have influenza, we have pneumococcal, we have some patients which can receive the human papillomavirus vaccine.
At a young age?
Yes.
And even in their 30s and 40s.
Yes.
So we have to evaluate if they are a candidate for that. And
Marcos,
we have,
if you're listening, you should be getting your HPV vaccine.
And also, you know which one, the zoster vaccine. Zoster now, here in Dominican Republic, we say like the culebrilla vaccine. That's the herpes zoster vaccine.
I see.
And that's for adults as well. And pneumococcal, I said.
I think the two most important vaccines for me is the varicella one for zoster and the pneumococcus, because pneumococcus is the first reason of death in people.
Older patients,
Patients, right? And in varicella, it's it's a very painful disease in older patients.
That's
too.
the chicken pox?
Yes,
Yes.
The chicken pox.
With varicella,
Yes.
but
and
the shingles
Shingles,
is
yes,
like the
definitely.
culebrilla here.
Do I
shingles.
need to get shingles vaccine?
Yes.
Depending.
Yes. Yes. don't ask the age. Yes, you have to get it.
The woman has spoken. I need to get shingles vaccine.
Yes, you have to.
I had, as a kid, I had chicken pox.
Yes, but you need the vaccine.
I
Then
still need
you need
it?
the vaccine.
you still need your vaccine.
Okay, I'm going to give you some controversial question, and don't take it personally, because every year we said, go get the flu vaccine. And I know for years I said, these are dead viruses. You're not going to get sick from them. Don't worry, it's fairly safe. And now we're finding out in America that, and again, I'm not against getting the vaccine. I'm just saying that the profile of the flu is like maybe 60% at best sensitive. And for whatever reason, I'm sure it's by luck, every time I got the vaccine, not for that 24 hours of surge, but I got sick.
Mm-hmm.
And the last couple of years that I didn't get the vaccine, maybe it's just all coincidence. I'm sure I'm okay. It is coincidence.
Yes, for sure. There are secondary effects from the vaccine, and it's like a flu-like illness that you get. Is not the
Short
flu.
term.
It's not the flu. It's like a flu-like illness. You feel like everything, and some people say, I got the flu even I got the as soon as I got the vaccine. But it's not. It's not possible that the vaccine is going to give you the flu. But you have to take in consideration two things. You get the flu vaccine, it protects you from complications. Pneumonia, which is the first
And even
thing.
if you get it, it probably would be much lower symptoms.
Yes, much lower. You get you're protected against pneumonia from the influenza and pneumonia from the pneumococcal that he already told you. So those are like the first reasons that you have to think. Okay, the first day I get the vaccine, I know I have.
So you recommend it?
Of course.
Yes, I think the influenza vaccine have to be focused. Yeah, I know that they send it for everybody. They say, oh, everybody have to put this vaccine. But in my opinion, I think it had to be focused to people with risk, like earlier patient, pregnant, and that kind of patient that can complicate for pneumonia or other things. Because as you said, the effectiveness of this vaccine is not 90%, 100%.
Understood.
Usually it's 50, 60%.
How is it at home? So you guys work and then you go home. Do you argue about these viruses?
We used to.
Do you fight over how the hell did you treat this like this? You should have given this. Is there an argument between you guys?
We used to, but now.
Who argues more? He does, probably.
No, she organizes more.
She's
No,
in
that's not
charge.
true.
Yeah, she's the chief.
She's
No,
in-
well, it happened.
Well, it looks like you gave up. The antibiotic is not working for
I
you.
gave
anymore.
up.
It happened before. Before we used to. It's not possible that go home and not talk about our patients. That's not possible. Even I see a very difficult patient.
You run it by him.
Yeah, I talk to him. What do you think about this? And
Well,
all
that's
those.
great for the patients.
Yes, that's great. But before, long ago, it used to happen that maybe he saw a patient. You know, when they call me, sometimes I say, if you're in homes, go and see this patient because I'm not there. And when I see, why did you put that antibiotic?
Yes, we have like a little
you know,
different
why did
style.
you put?
Yes,
Yeah, but now that usually doesn't happen. Now
I call her first and tell her, what do you think? I
Yeah, you
have to-"
better be careful with what
Yes.
treatment you
What do you
learn.
think about this?
Yes.
That's not true. That's not
Okay,
true.
tell me about like your experience in Santo Domingo. You've been in Santo Domingo for how long now?
Now, like 5 months. So it's like we're beginning, you know, slowly, but we are seeing patients.
Where are you seeing patients?
They're in Medwork.
Medwork Global in Piantini.
in Piantini, yes, on Wednesdays.
Okay, so
So-
1 week a month
Exactly.
One day a
One
week
day
you're
a week,
here.
exactly.
for people that have infectious disease and you want to get a second opinion, obviously in Santo Domingo, but also in Santiago.
Exactly.
Is there a specific website or phone number that we can give to people where
Yes,
if they're...
where they can find us.
How do we do? What's the best way?
One of the good ways is Instagram. You can find us. We have a very good
What's
page.
the name?
It's
Infecto team.
Infecto Team on Instagram, and the
Yes.
phone number?
829-679-9990.
Say it in Spanish, por favor.
829-679-9990.
Good. Any other messages? Anything else you want to tell the public about how to protect themselves against infection, and if they're in trouble, how they should come and see you? You can say it in Spanish now.
Yeah, dos cosas. Primero, a que todo el que está sano, vacunarse. Recordar todas las medidas de prevención de infecciones respiratorias que ahora circulan mucho, siempre están circulando, y evitar la automedicación. Nada de ir a la farmacia, al colmado, a comprar pastillas y medicarse por sí mismo. Vaya a la consulta que ahí le buscamos la vuelta.
Perfect. Doctor?
No, si te metes en un lío y necesitas consejo,
I think what he's saying is whatever she says, I will follow. I don't ask any questions. She writes the prescription. I
she's
just
the one.
Go ahead.
No, I'm telling that if you have any concern about STD or infection.
No. Go ahead.
Okay.
Sometimes I bring sense of humor,
Okay,
and I
that's
should tell
right.
myself, stop it.
That's okay.
Pero, por ejemplo, esas enfermedades de transmisión sexual que traen muchas preguntas, preocupaciones, a veces hasta malas decisiones sobre cómo abordarlas, pues en el servicio de infectología pueden encontrar una buena mano, un buen consejo, un buen abordaje, un buen tratamiento. Siempre traten de ir solo, no con la pareja, porque es más fácil.
I think they are being too nice. I think that there are a lot of people, especially with heart disease. As you know, when you have heart condition, your immune system is down. People that are especially on steroids and their immune system is down, they're susceptible to get this kind of infections. Diabetic is a nightmare. If you're a diabetic patient, a small infection in your feet, small infection in other parts can turn into a big abscess. I remember one of my own cousin had a dental cavity that because of uncontrolled diabetes, hemoglobin A1C of 8, and it didn't take care of him. That dental cavity turned into an abscess. The abscess got into his system, and unfortunately, he died from that. So I don't, I want to tell you how important it is to have a great infectious disease doctor on your side. They can save your life. They are very humble. They're extremely nice. I know them for many years at homes, and they are ready to help if you have any of this. I appreciate you being here.
Thank you.
Thank you
And
very
thank you
much.
for taking care of our
Next
patients.
time I'm going to vaccinate you.
Oh, boy.
Next time we see, I'm going to vaccinate
Start with
you.
shingles, and then we're going to go all the way. Thank you very much.
Thank
Thank you
you.
for coming.